Welcome everyone, and thank you for joining us. My name is Tanya Long, Senior Manager of National Education for Osteoporosis Canada, and I am very pleased to be your moderator today. Each Bone Matters Take Charge Health presentation is led by a Canadian expert in osteoporosis to help participants better understand how to prevent the next fracture and how to live well with osteoporosis. Bone Matters is an ongoing series of live and archived presentations, and today we are delighted to welcome our guest, Dr. Nesha Yüksel. There is no single cause of osteoporosis. One form is called secondary osteoporosis and is caused by certain medications that contribute to bone loss and fracture risk. In this presentation, Dr. Yüksel will consider the effects of drug-induced osteoporosis on bone loss and fracture risk. She will also look at how drug-induced osteoporosis is assessed, how you manage drugs that lead to bone loss fractures, and which drugs do contribute to bone loss and increased fracture risk. To submit a question on the panel on the right side of your screen, you will see a box that says questions. Type in your question in the text box and we will receive your question to ask at the end of the presentation. You may submit at any time and it will be addressed in the Q&A period if time permits. If not, we will answer the question after the presentation. So please be sure to include your email address in the body of your email so that we are able to send an answer. Dr. Nesha Yüksel is a member of the Scientific Advisory Council of Osteoporosis Canada. She is a professor in the Faculty of Pharmacy and Pharmacy Sciences, University of Alberta. Her research interests focus on aspects of women's health to improve the quality of women, particularly with regard to women and osteoporosis. She has won a number of awards, including Canadian Pharmacist of the Year from the Canadian Pharmacist Association in 2016, and the Faculty of Merit Award for 2012 from the University of Alberta. We are very pleased to welcome you, Dr. Yüksel.
Well, thank you very much, Tanya, for that lovely introduction. Hope everybody can hear me okay. I'm really happy to be presenting this webinar on drug-induced osteoporosis. This is a topic that is near and dear to my heart. I work in on top of being at the Faculty of Pharmacy, I also work in a multidisciplinary bone health clinic. And we see a lot of patients with drugs that can have negative effects on bone health. And I'm going to be talking about some of those today. And these are my conflicts of interest. So what is drug-induced osteoporosis? When we talk about drug-induced osteoporosis, that is the use of any medications that can cause further bone loss and can lead to fracture. So think of any medication. There's a long list of medications, but what I'm going to do today is talk about some of the more common ones that we see, and also the ones that I get a lot of questions about as well. So today's objectives, I know Tanya summarized it briefly, but what we're going to do is talk about the effects of drug-induced osteoporosis, to consider how drugs that may affect bone health are assessed, look at the management of drugs leading to bone loss and fractures, and then discuss some common agents. There's a long list, as I mentioned already, but we're going to pick some specific ones to talk about. So first of all, we're going to do is understand the effects of drug-induced osteoporosis. So as you know, osteoporosis is a major public health concern. 1 in 3 women and 1 in 5 men, so very common, over the age of 50 will suffer a broken bone from osteoporosis over their lifetime. Now, many classes of drugs have been shown to lower bone density and or increase fracture risk. But unfortunately, we do not know the overall incidence or how commonly this occurs for drug-induced osteoporosis. And likely, we underestimate this risk. Now, what is the issue? Well, we know that people are not always screened and actions are not always taken to prevent drug-induced osteoporosis by healthcare professionals and also by people understanding their risk. Now, we need careful screening and assessment is required so that we can know how to manage drug-induced osteoporosis. Now, we do have some guidelines for a few classes of drugs that affect bone health, and I'm going to talk about some of those. But unfortunately, for a lot of these, guidelines don't exist. So we often have to use clinical judgment. So next I'm going to talk about how to consider how drugs that may contribute to bone loss are assessed. So some things to think about is that not all drugs that are said to affect bone health have a proven cause and effect on bone. So we don't always know, even though they say it may affect bone health, we don't always have the good evidence or good studies that say that it actually does. And one of the reasons is that some of the mechanism of action of these drugs on bone is not always clear, and it may not always be feasible depending on the drug. So we'll talk about some specific ones later. The other thing that's really important is we need to consider other factors as well that may impact bone. I'm going to talk about that in the next slide. So some of the factors we need to think about is the effect of the underlying disease on the bone health. So the underlying condition of why they may be using that treatment. For example, it's known that anti-seizure medications can possibly lead to bone loss and fractures, but also seizures, just the fact of having a seizures disorder can also lead to fractures. So that's the thing it's how do you sort that out? You need to also think of other drugs that may be taken at the same time to treat the underlying disease. Maybe it's another drug that we're using in combination to treat that disease that may also be affecting bone health. So maybe in cancer, if they're also using a corticosteroid, which we'll talk about, maybe that's also affecting it. So thinking of the big picture. And then we have to think about the effect of medications on falls. We know that falls can lead to fractures, and a number of these medications can actually lead to a fall, which can lead to a fracture, and it may not always have a direct effect on the bones. So some things to think about when we're looking at the impact of these drugs on bones. How does the drug affect bone health? Does it decrease bone density? Does it cause bone loss? Can it lead to fractures? What is the evidence? What are the studies? How good are those studies that have shown that? What is the mechanism of action on the bone? Is this a feasible mechanism of action? And is the effect on bones dependent on things like the dose? Is it dependent on the dose so that we can use a lower dose if that's the case? Or how long the drug is used. So if used for a long period of time, maybe we use it for a shorter period if we can. So when we're thinking about assessing patients or people that especially if they're on drugs that impact bone health, what are some of those things we need to think about? Well, we need to know how to identify people at highest risk of bone loss and fractures so we prevent those fractures from happening. What can be done to prevent bone loss and fractures? What are the actions we can take? And then are there guidelines to guide us in, as a health professional and a clinician, to guide us in what we need to do? Now you can see this table is very, very busy because this shows all the drugs that have been shown or implicated in impacting bone health. And it includes bone density, like the effects on bone density, so bone loss, and fracture risk. So does it increase the person's risk of fracturing? And as you can see, there's quite a lot on this list. Now, there are a few that have greater evidence. So what we mean by evidence, we mean by good studies to say that it actually impacts bone density and fractures. The most common ones that we have the best evidence includes the glucocorticoids, and I'll talk about those. They also include the aromatase inhibitors for breast cancer and the androgen deprivation therapy for prostate cancer. These all have strong evidence to affect both bone density and increase fracture risk. Now, there's a number of other ones on this table as well that have different effects. Some affect bone density, some affect fracture risk, some affect both. And the evidence of studies is not as clear, even though we're getting more and more information about some of these drugs, not always so clear of what we need to do with these. And I'm going to talk about a few, and I'm not talking about all of these, but if you have questions, I'm welcome to answer them. I'm just going to talk primarily on some of the more common things that you might see. So next we're going to review the management of drugs leading to bone loss and fractures, just the general management. And what's really important is that we need to screen for drugs that impact bone health. We need to be able to identify people at highest risk of bone loss and fractures, and then we need to treat those people at highest risk. Now, we do have several tools as clinicians that we use to assess fracture risk. And we base these tools on includes risk factors as well as bone density. And a couple of these tools that we use in Canada include FRAX and KROC is another one. And you may have heard of these tools, but what these tools do is give an assessment of the risk of fracturing in the next 10 years, but it also gives us an idea of where people fit if they're high risk and need to be on treatment. But the issue with these tools is that these are not all designed to assess fracture risk for a lot of these drugs that I mentioned. The only one that is actually specifically included is glucocorticoids, such as prednisone, but a lot of the other drugs are not included. So we have to make some clinical judgment as well on top of these fracture risk assessment tools. So let's look at some general recommendations on how to go about managing drugs that affect bone health. Well, we want to, of course, balance the benefits of treatment with that medication or drug to the risk of bone loss or fracture. So if we really need to have that treatment because we're going to see lots of benefit, we may decide to continue even if there is a risk of bone loss or fractures, and we may need to monitor or start medications, osteoporosis medications. We should always reassess the need for that medication if possible. And if there's another medication that can be used instead, we maybe should switch, especially if that medication does not have an effect on bone loss or fractures. We can use the lowest dose, the shortest duration, but it also depends if that drug is, the effects on the bones is dependent on dose or duration, but we should be always considering that. We should always get adequate calcium and vitamin D. And Osteoporosis Canada recommends at least 1,200 milligrams of calcium daily between diet and supplements. And then vitamin D, anywhere from 800 to 2,000 international units daily of vitamin D is the current recommendation from Osteoporosis Canada. We should always consider lifestyle measures as well, and that is on my next slide. And we should all be educated on risk factors and lifestyle measures, not only if you're on drugs that affect bone health, but we should all be thinking about this. So these are all recommendations that are consistent with what Osteoporosis Canada recommends. We should all be getting exercise, and the recommendation now is about 30 minutes physical activity most days of the week. I would strongly recommend to look at the Osteoporosis Canada website, and they have a great pamphlet called Too Fit to Fracture. And what this pamphlet includes is recommendations for types of exercise, thinking about things like aerobic, balance, strength training, and they give great recommendations for that. So I would strongly recommend for you to look at that. Obviously, stop smoking. Smoking increases further bone loss and fractures, so we do recommend trying to quit smoking. Limiting alcohol intake. Currently, the recommendation is less than 2 or less drinks of alcohol drinks per day is the recommendation, if not going over that. Limiting caffeine, because it can also increase risk of further bone loss. The recommendation is less than 4 cups of coffee per day, which is about 400 milligrams of caffeine, depending on the type of coffee you drink, but it's around 400 milligrams is the recommendation of less than that. And of course, we all need to be thinking about fall risk. And one of the ones I want to mention is about be careful of medications that increase risk of falls. And there is a long list of medications that can further increase the risk of falls because falls can lead to fractures. So what about specifically the management of drug-induced osteoporosis? Obviously, we're going to be looking at those lifestyle measures, as I mentioned, but there's some things we need to be thinking about or considering in management of this. So the options include, we can consider switching to a different medication that has the same effect on whatever it is being treated for the disease or condition, but maybe it doesn't have the same effect on the bones. We can start an osteoporosis medication to prevent further bone loss or fractures, especially if the patient is at high risk for bone loss and fractures. Or we continue on the drug, so no additional action, and just do the lifestyle measures that I've already mentioned. So what I want to do next is discuss some common agents associated with drug-induced osteoporosis. So the first class, and probably one of the most common classes that can lead to drug-induced osteoporosis, is the glucocorticoids. And this is a common cause, as I mentioned, and they include drugs like prednisone. Dexamethasone is another one that you may see, but prednisone is a very, very common one. And because these are great anti-inflammatory drugs, they're used for many, many conditions, many inflammatory immune conditions. You see it in rheumatology a lot. You can see it even in cancer patients and transplant patients for a number of other conditions, lung disorders, a number of things. The way they affect the bones, though, and they have a pretty drastic effect on bones, is that they reduce the activity of our bone-forming cells called osteoblasts, but they also can increase the activity of the cells, the bone cells that break down bone, called the osteoclasts. And our bones are always going through normal remodeling, so we're always breaking down bone and building up bone, and we need normal function of both to have good quality bones. And so unfortunately, the glucocorticoids can affect both of these cells and cause further bone loss as well as fractures. Now, the effect on bones depends on the dose of the glucocorticoid and the duration, how long it's used. And we are concerned when we see people who need to be at doses of around 7.5 milligrams of prednisone daily for 3 months or more. In the previous year we look at, it doesn't have to be consecutive, but at least they've been getting that much of prednisone or equivalent to the prednisone for that time period. Now, bone loss can occur quickly. It can start in the first 6 months, so we need to look at this relatively quickly when we think someone's going to be on for that long of prednisone. And it mainly occurs with what we call the systemic routes. So things like the pills or the injection, it mainly occurs with these. And it doesn't really occur with things as much like the topical ones. It's not going to occur with, or even the injection directly into a joint. You're not going to see it. It's mainly the ones that we have a systemic levels in the body. And luckily, we do have guidelines to help us in knowing what to do. So how do we manage glucocorticoid-induced osteoporosis? And so we should get a bone density. We always get a bone density, and we assess fracture risk with that. So we look at those tools, we look at their fracture risk, the risks of the overall risk factors, and then look at their overall risk of fracturing. So options include is we can reduce the dose of glucocorticoid to a lower dose if possible, and even to a lower dose that may not be as much risk. Or if we can discontinue if somebody does not need it anymore. But unfortunately, sometimes people do need it ongoing to help with, whatever inflammatory condition they may have. Obviously, we're going to be educating on risk factors and lifestyle measures. We need to be thinking about these all the time. And when do we start osteoporosis medications? We would consider starting an osteoporosis medication if someone is going to be on that dose that I mentioned, the 7.5 milligrams of prednisone, and if they're going to be on longer than 3 months of therapy, we think that's going to happen at any point, we should be starting on osteoporosis medications. Now, we will consider sometimes in people who are on lower doses than 7.5 milligrams per day, if they have what we term moderate to high risk of fractures, we look at things like the fracs and other like CAROC to see what risk they might have. And so sometimes at lower doses, we may consider starting an osteoporosis medication. So which medications do we look at? Which ones are good to use to help prevent further bone loss? So the osteoporosis medications that we tend to use are the oral bisphosphonates, and that includes either risedronate or alendronate. That's the oral bisphosphonates. And we can also consider others, and they all have studies showing good fracture reduction. So we can think of the intravenous bisphosphonate called zoledronic acid, or A-class, that's the brand name. Denosumab or Prolia is the brand name, and then teriparatide can also be, there's been studies with that as well, and that's for TEO. Now, really, it depends on the drug coverage a lot of times in the province that you're at and what would be covered. In Alberta, we usually start with the oral bisphosphonates as our first line, unless there's some reason we can't use the oral bisphosphonates, and then we would look at something like the IV bisphosphonate or denosumab as our next. But usually our oral bisphosphonates is what we start with to prevent further bone loss and fractures if somebody's on the glucocorticoids. Okay. So the next class I'm going to talk about that also commonly causes bone loss and fractures is the aromatase inhibitors for breast cancer. And I've included some types for you on the slide. These are listed on here. I'm not going to go over each one, but they're listed on here in case you're familiar with any of them. These are treatments for hormone receptor positive breast cancer. And the way they affect bone loss is because of the way they work, and that's why they're of benefit in breast cancer, is they prevent estrogen production in the body. So estrogen levels become very, very low, and that's helpful for the breast cancer. But the issue is that our bones need estrogen as well. So it can affect further bone loss, and as well as I mentioned, can lead to possibly fractures if left for a while. Now, most of the bone loss occurs in the first year after starting, but it could continue, but you see the greatest. So really important to start and look at these patients relatively in that first year so that they don't have a lot of bone loss. And then it's reversible on discontinuation, so that's good. And then there are guidelines available to help guide us. So who do we treat? With aromatase inhibitors, we usually get a bone density to see what their bone density is like at baseline. And we look at the individual's risk factors for a bone loss and fractures, and then we assess their fracture risk. Obviously, we're going to educate on risk factors and lifestyle measures. So of course, we're going to do that. And we will start osteoporosis medications if they are high risk for bone loss and or fracture. So we don't start just because they're on an aromatase inhibitor, but we would start if they have a number of risk factors and we think they're at risk for further bone loss and or fracture. So we will assess the overall situation and then determine if they need to be on treatment. Now, the options for treatment include the oral bisphosphonates, including risedronate or alendronate, and often this is where we go first line just because of coverage, and especially in Alberta. But we can also consider the intravenous bisphosphonate, zoledronic acid, and denosumab. All have studies showing good response. But often we'll start with the oral bisphosphonates as our first line, and then switch if someone does not tolerate or they continue to lose bone density, and things like that. Next I'm going to talk about is the androgen deprivation therapy for prostate cancer for men. And the role of this androgen deprivation therapy is treatment for prostate cancer. And you can see there's a number of different classes of androgen deprivation therapy that are listed, and the medications are listed for you as well. And so I'm not going to, as I said about the aromatase inhibitors, I'm not going to talk about each of these, but they're there for your information of what I'm referring to for androgen deprivation therapy. Now, the way these work is that they decrease testosterone in the body, and that's how they work for prostate cancer. So they decrease it similarly to what I said about the aromatase inhibitors with estrogen. Similarly, these decrease testosterone in the male body, and they by doing this, they help with the prostate cancer, but our bones also need testosterone. And so by decreasing testosterone in the body, it can lead to further bone loss and possibility of fractures as well. So that's where the mechanism comes up. Now, most of the bone loss occurs in the first year after starting, so very similar to what I already mentioned with the aromatase inhibitors, and it's reversible on discontinuation as well. And there are guidelines available to guide us, and the guidelines actually look very similar to what I mentioned about aromatase inhibitors. We want to get a bone density, we want to look at risk factors for further bone loss. We want to assess their fracture risk with that. We're going to educate on risk factors, look at lifestyle measures. We should all be thinking about this anyway. And again, we only start osteoporosis medication if the person is at high risk for bone loss and or fracture. So similar to what I mentioned already, if they're on androgen deprivation therapy, it doesn't mean we would start an osteoporosis medication right away. We would assess if they're going to be at high risk based on other risk factors that that individual might have, and especially if they're at risk for further bone loss and fractures. So the options for treatment actually look very, very similar as well. We usually first line, we go to the oral bisphosphonates, either risitronate and alendronate. And in the clinic that I currently work at, we do see a lot of patients on androgen deprivation therapy for prostate cancer. We also see a lot of the glucocorticoid ones as well, as I mentioned already. But we do see quite a few, and we usually start with an oral bisphosphonate first, so like something like risitronate first. The IV intravenous bisphosphonates, zoledronic acid, and the denosumab, Prolia, are also options, and good studies have been shown. But because of what is covered in Alberta, we tend to go with the oral bisphosphonates unless they meet the criteria for one of the other ones. And each province is going to have a little different criteria, and you should check with your family physician, or if you have a specialist that you work with, what that would be. Now, there are some guidelines for this area that state that they have preference for denosumab over the bisphosphonates, because these, in the studies that have been done, the denosumab has been shown to decrease fractures, and that good studies have shown to decrease fractures. But again, for us in Alberta, it really depends on what is covered. And again, it's going to be different from province to province with that. So I finished talking about some of the common ones that have good evidence. Often we need to screen patients. We need to often start on a medication depending on if they're at risk or not. What I'm going to do now is talk about some other drug classes that I get a lot of questions about. These drug classes don't always indicate that we have to automatically start on medication. We wouldn't normally start an osteoporosis medication for these, but we need to be thinking about these medications especially to reduce the risk of any negative effects on the bone health. So the first class I'm going to talk about are the proton pump inhibitors, or PPIs. And many of you might be familiar. There's a number listed on here. You may be familiar with their brand names more, such as Losec, Pantoloc, Nexium, Prevacent, and Dexilant are some of the names out there with that. And all these drugs work is by acid suppression. So you might see it on reflux disease or ulcers or those kinds of things where they may be used. And they are very, very frequently used. A lot of people are using PPIs. Now, we don't really know the mechanism of how these work on bones. We really don't know how the negative effect is. There are some theories. One of the theory is that because the PPIs suppress that acid secretion in the stomach, it can affect normal calcium absorption. So we don't see normal calcium absorption. So maybe that's the effect on the bones. Another theory is that it may have a direct action on osteoclasts. Osteoclasts are the bone cells that continue to break down bone or cause bone resorption, and they may have an effect on that by causing an increased activity of these, but we really don't know. So we do know that the PPIs have been shown that to increase the risk of fractures. But bone loss is not as clearly associated in studies. So sometimes just doing a bone density, if you follow, it may not always show up because it may just, it's been only primarily shown to increase the risk of fracturing. The risk is with higher doses of the PPI and longer duration of use. So trying to keep the doses low and not using for long periods of time is something that's recommended. The fracture risk does go down when the PPI is discontinued, so that is good. But one of the complicating factors is that PPI use may also increase risk of fall. So they've been shown to increase the risk of fall. So what we don't always know is it the increased risk of the fall in the individual, or is it the direct effect on the bones? So this is not really clear. Unfortunately, we don't have any guidelines to guide us as clinicians, but some of the suggestions include we should stop the PPI if we do not need it and really reassess the need for this. To use the lowest dose and the shortest duration, and maybe only use it as we need it. If we have reflux and the reflux starts acting up, then we use it for that situation unless we have ongoing chronic reflux. But if it's just for that, then we use it intermittently for that time period and then stop for a while. So this is sort of things to think about. We can also consider switching to a different acid suppression drug, such as the H2 antagonist, such as ranitidine, is an option. They don't have the same effect on the bones. One important thing to think about is that if you are on a PPI and you are taking a calcium supplement to supplement your diet, you should be not, I would avoid using the calcium carbonate in this situation, and I would recommend something like calcium citrate because the carbonate requires normal acidity in the stomach for absorption. And so we recommend the calcium citrate on that. So normally I would recommend carbonate or citrate in individuals, and the carbonate as long as you take it with food. But if you're on a PPI, I would recommend the citrate over the carbonate. Okay, so I'm going to talk a little bit about anticonvulsants or anti-seizure medications. And these are medications that are obviously used to help prevent seizures, but you may see these used for some other conditions as well, but often used to help with seizures. And some of them are listed on the slide here on the left. Now there's a lot of different anticonvulsants and anti-seizure medications, Not all of them have a negative effect on bone, but what I've included on this slide is the ones that actually do have more of a negative effect. Unfortunately, the mechanism is not well understood, how these can affect bones. The anticonvulsants can cause further breakdown, so what we call increased metabolism of vitamin D, so can induce the metabolism, so a greater breakdown of vitamin D in the body. And this is one of the theories of how it may negatively affect bones. So that might be the cause, but we don't really know for sure. The other complicating factor is that fractures may also be associated with seizures. So people who have seizure disorders can see fractures. So is it from the anticonvulsant or is it the fact of the seizure? Now, unfortunately, we don't have any guidelines available to guide us. The suggestions include that we obviously should look for screen for risk factors for osteoporosis. So if you are on an anticonvulsant or anti-seizure medication, we should also be screening for other risk factors for osteoporosis. Consider lifestyle measures for bone health. We should be doing that in everybody, obviously. Some people may require a higher vitamin D dose, so you might see doses of anywhere from 2,000 to 4,000 international units, especially if their vitamin D is getting broken down faster. And if there is significant concerns about bone loss or fractures, the suggestion is to maybe change to a different anticonvulsant if possible. Sometimes you can't, but if possible, that may not have the bone effects. So that's some of the guidelines, not guidelines, but current recommendations. So finally, I'm going to talk about a very common medication, an antidepressant, and these are the class called selective serotonin reuptake inhibitors, or as you would know it as SSRIs. So very, very common. A lot of people do know about SSRIs, and they're very commonly used. Some of the SSRIs I've included on this, and it's a class effect overall. So these, you might be more familiar with the brand names, Prozac and Paxil, Celexa, Cipralex, Zoloft, and Luvox are some of the ones that, or these are the ones that are available in Canada as SSRIs. The mechanism on bone is not very clear. They may have a direct effect because they work on serotonin preventing reuptake. They may actually have a direct effect, and there's actually serotonin receptors on bone cells, and they may actually have a direct effect on the bone cells. I'm not sure how, we're not really clear, but maybe that causes further effects on, negative effects on causing bone loss, maybe on the preventing or increasing bone resorption, and some of those things. But but again, not really clear. So we do see an increase in fractures with these, but the bone loss effects are not clear as well. So in studies, they've shown to increase fractures, but that bone loss hasn't been as evident. The other complicating factor, just like I mentioned about PPIs, is that SSRIs can increase fall risk. So it can increase a person's risk of falling. And in fact, the increase in fractures, the risk of increase in fractures has been seen within a few weeks of starting an SSRI. That's pretty fast, and it shouldn't be, you wouldn't see that fast if it was a direct effect on bone. So the falls may be the initial reason for increase in fracture. So maybe it's a combination of things, but we just really don't know, but it can increase fall risk. Now, unfortunately, there's no guidelines available to help us. Some suggestions include use the lowest dose of the SSRI as possible, if possible, and sometimes we do need to use higher doses, but if possible, we can use the lower doses. Obviously, we're going to screen for risk factors for osteoporosis, as we would consider our lifestyle measures for both bone health. And then if we have a concern about overall bone health, maybe someone who has a lot of risk factors for bone loss or fractures, we can change to a different antidepressant, maybe that does not have the same concerns. And most of the other antidepressants don't have the same concerns on bone health as the SSRIs or effects on serotonin. So finally, I have summarized some of the more common drugs and that have negative effects on bones. And obviously I didn't go over all the different drugs, but I just wanted to highlight some of the more common ones, probably ones that either you've heard about or you may be on yourself, or or a family member may be on. It's just some things to be thinking about. And I wanted to present sort of as a clinician, what would we do in that situation? How would we go about assessing? How would we be going about managing some of these? So just some final points. When using drugs with negative effects on the bone, we obviously have to consider the benefit to risks of using the drug. So the benefit to the person, the benefit to whatever condition they're using it for, and the risk on the bone health. So depending on if they're going to get the benefit, we need to use it, we don't have another choice, and obviously we need to be thinking, how do we monitor, how do we manage the risk on the bone health? We're going to be assessing bone health overall. We're going to look at risk factors. We're going to calculate out the risk of fracturing and looking at their overall issues and possibly to be able to prevent further fractures. We should always be considering other factors that may increase fracture risk, such as fall risk. And I know I mentioned about fall risk before, but we need to be thinking of all of those factors. And we should always be thinking about our lifestyle measures and approaches for bone health, including our calcium and vitamin D, exercise, quitting smoking, limiting alcohol, and some of those other caffeine and some of those other ones that I already mentioned. So thank you. That's the end of my presentation, and I wanted to leave enough time for questions. So I'd be happy to answer a few questions that you may have. So I think I'll be getting some questions.
Yes, thank you very much. And we will move right into the question and answer period. We have a few, but if anybody else wants to add any, please go ahead. I'm going to ask Matthew to read the questions for you.
So I'm going to try my best to pronounce some of these drug names correctly. So my mother has been taking letrozole 2.5 milligrams for 2 years. She is 85 and also has osteoporosis. Although it can contribute to bone loss, she does not want to change to tamoxifen, as it is less effective for cancer treatment and she is tolerating letrozole. Is there any way to mitigate the bone loss from letrozole? She cannot tolerate bisphosphonates and does not want to have Prolia injection.
Well, that's a good question. I think it's more, she's probably being assessed by her oncologist, as well as, I don't know if she's being seen by an osteoporosis specialist. That might be something to recommend, to be seen if there is someone that she could be assessed for the osteoporosis. Currently, our recommendations for, obviously we would look, and it sounds like she has osteoporosis. We would look at her risk of fracturing, so get a better assessment. This is what we would do in our clinic. We currently, the recommendations right now at this point in time is either the oral bisphosphonates or the IV bisphosphonate. The zoledronic acid is another option, and it's a once a year. And then finally the Prolia, the denosumab. So again, I think it's discussing, having those discussions with your mom by some specialists who can go over sort of the risks and benefits of each of those. And it's hard to do that, and I couldn't make a specific recommendation at this point in time. Now, there are newer agents coming out, but at this point in time, we don't have the data specifically for that population, right? So this is based on the current information and data we have. But yes, if she has a high risk of fracturing, if she has osteoporosis, it's probably using one of those medications to prevent further fractures from happening.
Okay, thank you. Second question. Do beclomethasone and Alvesco cause osteoporosis after long-term use?
Can you say that again? Which ones?
Beclomethasone and Alvesco.
Yeah.
Maybe for that one, is that possible one that I could answer through an email?
Definitely.
Sure.
Yeah, just so that I just don't want to, I just want to kind of see how that's written and everything. So maybe I could do that on an email if that's possible.
Sure.
That's great. Thank you.
Next question. Besides the early fall issues with SSRIs, what are the long-term effects on bones?
So the long-term effects, they have been associated with fractures, with the SSRIs, and it's not only from the falls, though probably the early one is probably from falls, but the long-term effects have been also associated. So maybe it wasn't as clear in my presentation. I wanted to say that often the fracture risk in some people happens early, but that might be from falls, but they have been associated with long-term fractures as well. Not as clear with the bone density, but with the fractures. The evidence in the studies, that's the issue, is when you're looking at types of studies and how good the quality is, but they have been associated with that. So that is also long-term use with it. So the increased risk of fracturing, not just on falls, but maybe that direct effect on the serotonin, with the serotonin receptors.
Next question. What happens when you require multiple medications that all have an effect on bone loss?
That is a very good question, and we don't really have a good answer for that. But the unfortunate thing is, a lot of times we don't have the studies to say exactly what that is. Like, is it multiplication, or is it a factor of, quadrupling your risk? We don't really have a good answer. But what we need to do is think about each one, what they can contribute to the effect on the bones, and consider both, that maybe there is that additive effect, but we just don't know what that risk would be. But we would be looking at all the drugs that could possibly affect the bones and trying to change the drugs as much as possible that we can, the ones that affect the bones, and maybe some we can't and some we can, but the ones we can, we really should be looking at changing those, especially in someone who is at risk. Maybe they already had a fracture, or maybe they are, have osteoporosis already, and we need to be reducing all of those drugs, not only the ones that can affect fractures on bones, but also those fall risk too. So we need to look at everything, and it's one of the things that we do in our, like the clinic I work in, is looking at all those drugs, and can we change one? Can we change this one? Can we reduce the dose of that one? So we need to be thinking of all of them. Absolutely, it's a great question, but always, but we don't have a great answer to say exactly what that risk is.
Is there any impact of high blood pressure medication on bone density?
The greatest impact of blood pressure ones is the fact of they can lead to falls. That is probably, with a lot of the blood pressure ones, can lead to it. But obviously, you do need to be on the blood pressure medications, which is probably more important to kind of keep that the blood pressure in a good pressure. So that's that whole benefit to risk. So we would it would not be the reason to stop a blood pressure medication if there is a concern with that falls, but especially if they need it. But we would look at all the other fall risks. So that's the bigger thing than a direct effect on the bones. The direct effect on the bones is not as clear. The ones I've talked about more today has been a little bit clearer, but they're not as clear.
Okay, and in that question, there was a specific blood pressure medication mentioned, so we'll pass that question on to you via email, so you can.
That sounds great. Yeah, that sounds really good. Now I know that one of them in that that might be, there are certain types of diuretics that have been associated, but questionable how much they're associated. So there are certain diuretics, so it depends on if it's that diuretic. But as a class of blood pressure medications, but there's quite a few different ones, they don't as a class have a direct effect on the bones. I hope that helps answer. But if when I look at the email, I'll be able to know clearer which one is being referred to.
Can you mention any new osteoporosis medications coming to Canada in the next 5 years?
Oh, in the next 5 years, there is a new one that just actually, I think it just became available just, I gotta double check and make sure it's actually in Canada right now, but I think it just came available, and it's another, just 1 second, I'm just gonna make sure that it is available in Canada. Yeah, and I'll let you know, just maybe I'll answer the next question, but I'll come back to that because I just want to double check before I say anything on here. Because I just heard about it yesterday, but I just don't want to make sure I got the right information that it actually became available. But there are other ones, a number of other ones, especially more like the biologics that are like there's other types of somewhat like the Prolia-like types that are coming out, that are, not coming out, but are being investigated right now to possibly. But there are a number of ones. I'm just going to take a quick look. But if there's another question, I can answer it.
Yeah. Will Gravol lead to falls in seniors in any way?
Gravol can, because Gravol can cause the type of medication. It can cause, sleepiness, and in some patients it can cause kind of that dizziness, that kind of thing, and that could lead to a fall. So it can lead to falls, yes, absolutely. Yeah, it can lead to falls.
And the last question is, are you willing to share your presentation with the audience?
Yes, absolutely. It can be shared with the audience. That's no problem. I'm just going to go back to the medication that just, and I think it actually just came out, and and there is a just one. It's like what we call the biologics, like the Prolia type kind of classes, but has a different mechanism. But it's the Romosozumab, and it's the Avenity is the brand, I believe. So it's pretty new. I think it's just a brand new one, but we don't know where it's going to fit right now in the overall, and then also coverage right now by different plans because it's so new. But that's the newest one, Avenity. But I just heard about it yesterday that it came out, so it's pretty new.
Okay.
And there's a final question, is whether or not Boniva is coming to Canada.
Oh, I don't really know if Boniva is coming or if it will ever come to Canada. Not sure. Not sure if it will. It's another.
If I can just interject, I would say probably no, because Boniva's been around for a long time. And if the manufacturers had any interest in bringing into Canada, it seems to me they would have done that quite a while ago.
Usually that's the case for a lot of the drugs, but there's another drug that's been around for a long, in the menopause area, that's just coming out in Canada that has been around for a long time in the world. But I agree with you, Tanya, that I don't think it's going to, and I agree totally with you in that case. I don't think it will. There's other drugs that are there's the bisphosphonates. It is a bisphosphonate, but there's other drugs that are coming out that you know, like some of those biologics that are going to have really good action as well. So I don't really know if it will.
And for the final question, can you comment on inhaled corticosteroids and their effect on bones? Corticosteroids.
Yeah, that's a good question about inhaled corticosteroids. At very high doses, so not often the doses that we use for asthma or COPD, but in some smaller groups of patients, they might use these really high doses. You can possibly see effects on bone loss and fractures. Now, is it the same amount to the degree that I talked about for the systemic ones, like the pills and stuff? It's not to the same degree as that, but in someone who may have some risk factors for osteoporosis and on these really high dose inhaled steroids, there may be a concern. So we need to monitor and follow. We wouldn't start automatically with an osteoporosis medication, but we would need to monitor their risk factors, their risk of fracturing, and look at it from that perspective. It's still not completely clear with that risk, but definitely with the pretty high doses you would need, and that could possibly affect it.
Yeah. Okay, perfect. So we have some other questions, but they're more specific with drug names and everything. So what we'll do, we'll email all of the questions we received during the presentation to you. And once you respond to those, as well as your presentation, we'll post those online to share with all of the group.
Okay. That sounds great. Well, thank you very much for letting me present. It was a joy, and thank you, Tanya and Matthew.
Well, on behalf of Osteoporosis Canada, I thank you, Dr. Yüksel, for today's presentation. No doubt your expertise will have answered many questions about drugs that can contribute to bone loss and how they should be managed. It was a very clear, easy to understand, and comprehensive presentation. So to the audience, let us know what you thought of the presentation by filling out the evaluation survey. You can access the survey via the link that will be sent to you in a post-presentation email or via the Osteoporosis Canada website. How can you find out about upcoming Bone Matters presentations? Notices will be published on the Osteoporosis Canada website under News and Events and through our social media feeds on Facebook and Twitter. Better yet, sign up for COPAN, the Canadian Osteoporosis Patient Network. All COPAN members are alerted to future Bone Matters presentations. And if you're not already a member, sign up for a free membership by going to our website at osteoporosis.ca/COPN. A very special thank you to everyone for coming today.
Thank you.